In an earlier recording about heart sounds, I introduced you to valvular defects. So I want to go a little bit more in depth in this recording. So as a reminder, if you have a stenotic valve, the valve doesn't open properly. And if a valve is incompetent or insufficient, it means it doesn't close properly and you'll have regurgitation. So during the cardiac cycle, during the phase of the cardiac cycle when a valve should be fully open, but it's not. If it's stenotic, it's going to create an abnormal sound during that phase of the cardiac cycle. If you have a valve that's incompetent, it's not closing. So if you know the phase of the cardiac cycle when it's supposed to be closed, but it's not, it's going to create an abnormal sound or heart murmur. So what I want to do is I'm going to look at this phonocardiogram, which is a visual depiction of heart sounds. A represents your normal physiologic heart sounds. Here's S1. Oops, sorry, that's S2. This is S1. S2, that's S3. And there is S4. So S1 was created by closure of the AV valves, which takes place at the beginning of isovolumic contraction. This signifies the beginning of systole. S2 is created by closure of the semilunar valves, which takes place at the beginning of isovolumic relaxation. This would indicate the beginning of diastole. So you can use those as references. So when we look at heart murmurs, we can classify those heart murmurs as being systolic or diastolic murmurs. So just by visual, by just looking at the picture where you see all these lines. So what this is represented is that these are sounds. The magnitude of these, the amplitude tells you how loud it is, and then going left to right tells you the duration of that sound. Okay, so what you'll notice is aortic stenosis and mitral regurgitation. You notice you're seeing something during systole. Those are systolic murmurs. Well, aortic regurgitation and mitral stenosis are diastolic murmurs. So let's reason this out. Okay, so aortic stenosis. This means the valve, aortic semilunar valve, is narrowed. It's not fully opened when it should. When should that valve be fully opened? Well, during ejection, which is part of systole, that valve better be open to get that blood out of the left ventricle into the ascending aorta. But if it's narrowed, you're going to create a sound during that phase of the cardiac cycle. So you see this systolic murmur associated with aortic stenosis. Now if you look at mitral regurgitation, that's also systolic murmur. Well, if you have mitral regurgitation, that means the mitral valve isn't closing when it should. So when should that AV valve be shut? Well, during systole, that should be shut because I don't want blood to go from your ventricle back up into your atria. So you'll notice during systole, you see that sound being created as a result of mitral regurgitation. So these two are systolic murmurs. If you look at aortic regurgitation, aortic semilunar valve should close at the beginning of ventricular diastole. Blood is going to that, remember that blood coming back closes the valve, but the aorta being a elastic artery that it is, blood will continue to move through your circulation, and we don't want that blood to go back into the left ventricle. But if it's not closing like it should, you're going to have this murmur, referred to as aortic regurgitation, that takes place during diastole. Mitral stenosis, the mitral valve should be open while the ventricles are filling, so blood should be going from the atria to the ventricles. You notice you don't really start hearing it till like mid part of diastole. Gets a little bit louder. This is when like atrial systole is taking place. So here that mitral valve isn't as open as it should, and so it's creating a murmur. Now I do want to bring your attention to, look at the magnitude here, mitral stenosis versus aortic stenosis. There's a big difference. Aortic stenosis is much louder because the left ventricle creates so much higher pressures than the atria, and so that sound is going to be much greater to try to get blood through that narrowed opening. Now, what will happen as a result of these valvular defects? Yes, obviously we can pick these up using cardiac auscultation, and I would be hearing these first two here between S1 and S2, so I'd be hearing some sounds between them. The aortic stenosis is actually described as a loud to harsh sound. Mitral regurgitation is characterized as being a blowing type sound, and you're going to be hearing it during systole. Now, aortic regurgitation and mitral stenosis, you're going to be hearing it after S2 before the following S1. Aortic regurgitation is also classified as being a blowing type sound. Mitral stenosis is a very low frequency. It's actually described more of like a rumble type sound. Now, what's the problem? What's the consequence of this? Well, all of them ultimately could lead to problems with getting blood out of the heart. It could affect your stroke volume, because if blood's going from the ventricle out to the aorta but then coming right back in, that's going to affect my stroke volume. If I have problems getting blood from the atria into the ventricle, that's going to create problems with stroke volume. So what will happen is we'll have some things that will take place over time to try to compensate for this. Now, early on, what can happen is, one of the things is, if our stroke volume is not sufficient, is we could increase heart rate. That's one thing that will happen, and we'll talk about that when we look at cardiac output. And might as well mention that the cardiac output is like a volume of blood that's ejected from your heart every minute. It's a rate. It's equal to your stroke volume, which is a volume of blood being ejected from each ventricle during a heartbeat, times your heart rate. So if I want to maintain an adequate cardiac output and I have issues with stroke volume, this goes down, I can compensate by increasing heart rate. I don't want to have to do that, because you don't want your heart to have to beat so hard. It takes a lot of energy to do that. And so what can happen is we can have some remodeling that takes place in the heart. So I'm going to show you, here is a coronal section through the heart, normal heart. Here's the left ventricle, here's the right, here's the interventricular septum. Notice the left ventricle is thicker than the right. It has to create higher pressures normally to move identical volume of blood. Now, here we're looking at, over here, we're looking at a cross section. Here's the normal right there. Now, I want you to look at this one. Look at the thickness of that left ventricular wall. And then look at this one. Here, I got a lot bigger space here. The thickness is a little bit thinner. And so what you're seeing is two different types of hypertrophy. So the one that you see here is called concentric hypertrophy, where the wall gets thicker. Over here is eccentric hypertrophy, where the wall gets thinner, but the chamber size, that lumen, gets bigger. So under what conditions will we get each type of hypertrophy? Concentric hypertrophy is a response to having to deal with higher pressures. So this is a response to increased afterload. It's a pressure load. Eccentric hypertrophy is a response to increased volume or preload. So these are concepts associated with the cardiac cycle that we're going to talk about in another recording. So concentric hypertrophy, if that ventricle has to create higher pressures to get blood out, it's going to get thicker. And so this would be a response to if you have a stenotic valve. Eccentric hypertrophy would be a response if you have a valve that was incompetent, didn't close like it should. So for example, right here, this could happen if you have aortic regurgitation. Blood is going to go back into the left ventricle, and then you're going to have more new blood coming in, so it has to accommodate a higher volume of blood. And so this is what happens over time. Concentric hypertrophy, if you're trying to, what you'd see here with the left ventricle, that would be in response to aortic stenosis. That is, you're trying to have to create higher pressures to try to get the same volume of blood through a smaller opening. This is the type of hypertrophy that would result. Both of them involve addition of, I hope you remember the term, sarcomeres. So you should have learned that in AMP1 about sarcomeres. And I'm going to draw you a picture. This is just my picture of a sarcomere, just very generic. So with concentric hypertrophy, you're adding more sarcomeres, remember actin and myosin, in parallel. So you're going to get the increase in thickness. With eccentric hypertrophy, you add more sarcomeres in series. Okay, so you get the thinner wall, but the lumen size gets bigger. So aortic stenosis, what can happen is the chamber of the heart that would initially have to work harder would be the left ventricle. And you would have, over time, you can get left ventricular hypertrophy, and it's going to be that concentric. Aortic regurgitation, left ventricle is going to work harder. Over time, try to compensate for it to maintain its efficiency. You're going to also have left ventricular hypertrophy. This type, though, is eccentric. Now, what about the mitral defects? So if I have mitral stenosis, what chamber of the heart is going to have to work harder? This time, it's the left atria. So you can get, over time, left atrial hypertrophy. And the type, again, because you have a narrowed valve, narrowed opening, it's concentric. Mitral regurgitation, it's going to be left atria again. Regurgitation. So it's left atrial hypertrophy. I'm lazy now. So left atrial hypertrophy, but it's eccentric. So this is just kind of looking at what can happen with some valvular defects on the left side. Now, over time, if when you're having, adding more sarcomeres or protein synthesis, you have to increase capillarity. You need blood. You need oxygen to that tissue. That doesn't take place as quickly as this. And so what can end up happening is potentially you could end up having ischemia, not getting sufficient amount of blood flow to that heart muscle. So you can end up getting myocardial ischemia. Potentially it can lead to heart failure also if they can't meet demands. So there's a lot of consequences that can happen over time if that heart has to work hard and hard all the time. I'm just going to leave it here because I just wanted to kind of go briefly over some of the valvular defects. I'll let you think about if I had the right-sided valvular defects. What I want you to do is do tricuspid regurgitation and stenosis, and also pulmonic regurgitation and stenosis. And I want you to answer these questions. I want to know for each of those valvular defects, when would you hear it? Which ones are systolic murmurs, which are diastolic murmurs? Second thing I want you to tell me is if I get hypertrophy, which I will, if with say tricuspid stenosis, tell me which chamber of the heart would be affected and what type of hypertrophy I would get. And that would go, you would do that for each of those 4 defects. So I want you to do that on your own. So this will be it for today.